Begin this session with benign tumors of the conjunctiva. This will be followed by malignant tumors of the conjunctiva, then management, and then histopathology. So to begin with, this patient came with a reddish papilliform mass near the inferior-medial fornix. What do you think? Is it a benign or a malignant lesion? Benign or malignant? What does the audience think? Yeah, there are feeder vessels, there are yellowish deposits seen. Benign or malignant? Okay. What about this? Extensive vascularization with the elevated papilliform mass on the limbus. Benign, malignant? Okay. Again, a papilliform lesion with feeder vessels and a lot of hemorrhage around it. Benign, malignant? Okay. So, these were a few examples of the common conjunctival lesions that we often see, and sometimes there is a doubt in our mind whether it's a benign or malignant. These are all benign lesions. We'll see in the following slides all of these. So to begin with, we'll start with the congenital conjunctival lesions which are benign. You all know what this is. What is this? From behind? Limbal dermoid, yes. So broadly speaking, limbal dermoids form in the category of choristomas, and choristomas are basically nothing but proliferation of a normal tissue at an abnormal site where that tissue is not supposed to be. So if that tissue grows there, then it's a choristoma. Now there may be many varieties of these choristomas, and another common variant is dermolipoma. This usually appears in the lateral fornix as a yellowish soft fleshy tissue. Sometimes you can see hair follicles arising from it, and if you image them, you will see a tail of fatty tissue which goes deep inside the orbit. The important thing here is when we treat them, you don't need to really chase the deeper part, you just need to debulk the superficial part, and that is usually enough. Now there may be variety of presentations of these dermolipoma. This patient presented with a pedunculated form of dermolipoma. That doesn't change the diagnosis. Another patient who presented with bilateral, medial and lateral dermolipomas. Now one may feel that when the case like this comes as to what is this atypical thing, but then this is another variant of dermolipoma. Sometimes they are not present in the fornices as always, but here you see an inferior dermolipoma and here you see a superior dermolipoma. So they may arise from some other sites as well, not just the classical lateral fornix. So when we operate, what we do is we remove these lesions superficially, because mainly the patient comes for a cosmetic reason, and the traditional teaching has been don't touch these dermolipomas. This used to be the teaching a few years back, because there will be a bad scar formed after that. But with the advent of amniotic membrane graft and fibrin glue, the scarring has reduced to a large extent. And so you can actually trim it, the superficial part, make the patient cosmetically better, and this is how this patient looked after the surgery. Another variant is complex choristoma. Now complex choristomas are again choristomas, but herein you find more than one type of tissue in the lesion. For example, the lesion may have fat cells as well as osseous transformation, and you may find some bony spicules or bony elements in the lesion. Then it's called a complex choristoma. Sometimes the complex choristomas may be associated with some systemic syndromes as well, as in this case of nevus sebaceous of Jadasson. If you see something like this, then you need to be a little careful and you need to monitor this patient, because these patients may have systemic features like mental retardation, seizures, and also increased propensity to have basal cell and squamous cell carcinomas. What these patients present with is, in the eye, they may present with a complex choristoma, and you see this patch of loss of hair, a localized patch of alopecia, along with a large pigmented plaque-like nevus on the skin, maybe on the face, maybe on the trunk or chest, anywhere you can see. But you need to monitor these patients for any further complication. Moving on to the adults, where the most common benign epithelial tumors are papilliform lesions or papillomas, as we see in the OPD. Now these may appear as pedunculated vascular tissues, may arise from fornices, And the difference which we see when such a lesion presents in childhood or in adults is that in childhood these lesions are much more red. They may bleed also a lot in papillomas of childhood, whereas in adults they are a little more pale and pink colored. Then this is seen. This kind of a lesion is seen in areas which are more which receive more sunlight, and in more sun-exposed areas, you see sometimes patients coming with a dry kind of a surface of a lesion close to the limbus, something which you may consider as a bite-out spot, but also has a lot of feeder vessels in it. Sometimes it's very it's difficult to differentiate it clinically from a OSSN or a CIN, and biopsy may be required. This is actinic keratosis. Basically, it's sun-induced damage, something which probably arises in patients who have a pre-existing pingicular or a pterygium, and then with solar exposure, they develop into actinic keratosis. This is a pre-malignant condition, so these patients need to be washed or the lesions need to be excised if you suspect a OSSN. Moving to benign melanocytic lesions, this is the commonest benign melanocytic lesion of the conjunctiva, conjunctival nevus. It appears as a flat or slightly elevated lesion close to the limbus more commonly. It may have a varied pigmentation at different parts of the lesion. It sometimes has a feeder vessel, so don't get scared if you see a feeder vessel there. Many of these lesions cases do have a feeder vessel. The typical characteristic is look for these microcysts. Can you appreciate these small microcysts? So if you make a slit lamp beam, you will be able to see these microcysts, and this goes more in favor of it being a benign lesion. These have less than 1% risk for malignant transformation. Few more examples of conjunctival nevi. In fair-skinned people, sometimes we see patients who come from abroad and they don't have a classical pigmentation like what we see in our Indian population. In these cases, they may have a slightly pinkish appearing lesion, but the presence of microcysts and the vessels like this, you know that it's a nevus, and you can tell this patient that nothing needs to be done and it has to be observed. Racial melanosis is quite common in our country. It's usually bilateral pigmentation, which is mostly seen in the palpebral fissure area and the exposed part of the eye, and usually it's symmetrical. Primary acquired melanosis is, as the name suggests, it's an acquired melanosis. Now, you need to be careful when you see a patient with acquired melanosis. It appears as a diffuse kind of a pigmentation, often in the palpebral aperture, but also can be seen in the fornices. And it's of two types. If you dissect it histopathologically, Kaustav will tell you that PAM can be of two types, PAM with atypia or without atypia. PAM with atypia carries a 46% risk of conversion to melanomas. Now, you don't need to treat all the lesions of PAM, all the cases of PAM. Suppose you see a patient who comes with a flat, irregular kind of a pigmentation on the conjunctival surface, you suspect it's a PAM. You don't need to treat all these patients. These are the indications for doing a biopsy as per the protocol. If the diameter is more than 5 millimeter, if there is a documented progression of the lesion, if there is nodularity within the lesion, if there are feeder vessels there, if there is corneal involvement or palpebral conjunctival involvement, then you need to biopsy these patients. They may be associated with dysplastic nevus syndrome also, and you must elicit history of cutaneous and rule out uveal melanoma in these cases. Management is wide excision with cryo. MAP biopsy can be required in very extensive lesions, and topical chemotherapy has a limited role. Now, sometimes these patients are referred to us with diagnosis of conjunctival nevus. If you look carefully, it's an irregular kind of a pigmentation, but the pigmentation looks slightly different from what we saw in patients with nevi. This is slightly more bluish color, and if you make a thin beam of the slit lamp, you will be able to appreciate that the pigmentation is coming not from the conjunctiva but from the episcleral tissue. And this is episcleral melanocytosis. Sometimes it can be associated with pigmentation of the surrounding skin as well. And in those cases where it's an oculodermal melanocytosis, you need to rule out uveal melanoma in these cases. You must always dilate the pupils and have a proper look at the fundi. Moving on to vascular tumors of the conjunctiva. This is the picture that I first showed. This is a pyogenic granuloma. Most often it is seen as an acquired lesion over sites of chronic irritation, sometimes following RD surgeries, more so in older patients where buckling used to be done was the norm. Nowadays the incidence has reduced although. So in cases of RD surgery, sometimes there are persisting sutures which irritate the conjunctiva for a prolonged period, and then these patients form these reactionary hemangiomas. Now, Kaustab, if I send this tissue to Kaustab, he will tell me it's a capillary hemangioma. So, this kind of an acquired hemangioma of the conjunctiva. Another example of pyogenic granuloma, this patient had a simple chalazion, but which burst, and because of the chronic inflammation, it formed a pyogenic granuloma over the site. You simply need to excise them from the base, and the lesions usually do not recur if you also take out the source of irritation as well. Now, these are many times we see these small cystic areas on the conjunctiva. These are prominent lymphatics, lymphangiectasias, and sometimes you see these prominent reddish kind of a fleshy mass in the fornices. This patient had a lymphangioma, and when we look at vascular malformations or vascular anomalies which are prominent in the conjunctiva, one must think in terms of whether it's coming from the orbit, because many a times the problem lies in the orbit, and what we see on the conjunctiva is actually just a tip of the iceberg, and major lesion lies behind. Another patient who presented with a reddish mass in the conjunctiva, this patient had a varix, was investigated, the orbital MRI was done, the patient had varices of the orbit as well. Sometimes we see conjunctival macrovessels, which are just prominent macrovessels, but if you see something like this, one thing you need to do is you need to dilate the pupil and also rule out an underlying melanoma, because sometimes sentinel vessels also appear similar. And then you may have tiny small vascular lesions which sometimes show a fluid blood level in the conjunctiva. These are tiny cavernous hemangiomas on the surface. Now, this is the patient that we saw in the first slide. This patient actually had a massive facial hemangioma. This patient was of Sturge-Weber syndrome. Sometimes these patients can have conjunctival involvement with the hemangioma as well, and because of chronic inflammation and chronic irritation, these patients are more prone to form granulomas also on the surface. Another patient with lesser involvement of the skin and fine vessels, cavernous hemangiomas you can see on the surface. Now, some of the lesser common tumors are fibromas, histiocytomas, neurofibromas. This patient presented with a yellowish, soft, very soft, something like a fatty consistency mass over the epibulbar surface. It was excised completely and it turned out to be a myxoma. Now, if you get a patient who's got a myxoma of the conjunctiva or the eyelids, you must get one investigation done. Which one? A systemic investigation. Which one is indicated? Okay. So, you need to get echocardiography done, because these patients also may have cardiac myxomas as part of Carney complex. Touching briefly about the caruncular lesions. Caruncle is a unique site as it's got sebaceous glands, sweat glands, and hair follicles also at times. So, it may have sebaceous cysts and other cysts arising from the sweat glands, and at times the most common tumor arising from caruncle is oncocytoma, which can be benign as well as malignant. So, that needs to be looked carefully and excised. Now, sometimes there is not a tumor, but there are some lesions which are simulating conjunctival tumors, like huge, large epithelial cyst, which may sometimes give a person doubt whether it's a cyst or a tumor. What is it? The cyst of the lacrimal gland, which is known as dacryops. It's a retention cyst. Again, nothing to worry. Fat herniation sometimes can give a confusing picture. Foreign bodies can look suspicious at times. This was some sort of a presbyopic implant which was placed by an ophthalmologist, and the patient did not remember the history properly, also didn't have any record, and we were wondering what is this exactly until we opened it up and removed it. And sometimes episcleritis, if it's not responding to conventional treatment, may give one a doubt whether it's a tumor. And this patient, which I first showed in the slide, biopsy was done, it turned out positive for tuberculosis. Cysticercosis can sometimes mimic a conjunctival mass, and you need to, if you suspect a cystic lesion, then you must do an ultrasound or an MRI to rule out a scolex. Another patient with cysticercosis, you can appreciate the scolex there. And staphylomas sometimes may mimic a melanoma with an extraocular spread or a large melanoma. So, you must always do a B scan, thorough B scan in all patients of staphylomas. And what is this? Can anybody guess? So, this patient presented with a blackish pigmentation. Okay, so there is the surrounding congestion there. The glow is a little pale, This patient actually was operated for RD a couple of days back, and there was a slight wound leak from which the pigment of choroid leached out. So this site was opened up, the pigment washed, and the wound secured. So this was a pigment leach from the choroid following VIA surgery. Thank you very much.